Welcome to our broadcast. I'm your host, Sarah Vaezi, Chief of Digital and Growth Strategy for Providence. As a reminder, the information provided during today's event is for informational purposes only. For any medical questions, please reach out to your primary care or healthcare professional. Now let's begin. I'm excited for today's conversation. Joining me for this event is Doug Grabsky. He's a senior manager of digital strategy within the Providence Digital Innovation Group. I get the pleasure of getting to work with him every day. And hey, Doug, nice to see you. So Doug and I are going to be talking today about a sort of series of reports and a tremendous amount of research that Doug has done over the course of the last couple of years around industry consolidation, some of the impacts that COVID has had, and generally the trends that we're seeing and some of the implications for digital as well as for health systems more generally. So it should be a really interesting conversation. And before we just jump right in, Doug, why don't you just introduce yourself and tell the folks a little bit about what you're working on within digital innovation today.
Sure, great. Thanks, Sarah. And yeah, happy to be here and hello to everyone out there. So I'm Doug Grabsky, a senior manager on the Providence digital strategy team. And really what we're going to be focusing on today is just how we've seen COVID accelerate a lot of trends in the digital healthcare space. And then, talking about what are the implications across payers, looking into some of the trends around, how provider landscapes and provider employment has shifted over the past couple of years, and then ultimately kind of dig into what does that mean for health systems. The whole competitive landscape has evolved, and what does that mean for us that are traditional health systems, and how should we respond?
Awesome. So let me just start with this question, which is of course, the last couple of years has been really a constant state of flux, a lot of disruptive care models emerging, a lot of capital flowing, a lot of really interesting exits, a lot of just acceleration of some pre-existing themes. Last year, you had made some predictions about what we thought would happen around industry consolidation, in your view, I know you segmented kind of the different types of consolidators and the different sources of value. You want to break it down for us? How good was our crystal ball? How did it kind of come out related to the different segments, if you want to get into that? Let's start there.
Sure. So I think our overall report, we were right on some of the more obvious things, thankfully. So we'll take that as a win. But some of the biggest trends that we predicted and ultimately saw was, the acceleration of care into the more distributed models, acceleration of care into the home. There's a litany of transactions that have happened around home-based solutions and getting more care directly into into consumers' homes. Those are some of the biggest trends that we saw. Also a big shift into more ambulatory settings, especially thinking about some of the ambulatory surgical centers, things like that, where we just saw tremendous growth of utilization throughout the pandemic, with fewer patients wanting to come into hospitals for fear reasons, safety concerns, all of those things. So some pretty big trends there. I think some of the things that we didn't predict as well, or didn't kind of see in our crystal ball, I think one area that we had called out of being less strategically important going into the pandemic, and really we still saw a ton of activity, was around academic medical centers, a lot of critical care hospitals. There were still a lot of acquisitions in that space. There was a lot of movement and focus in that area. And I think we got a little hyper-focused on some of the trends at home, and kind of forgot about or didn't think as critically about, hey, those are still really important assets. We still have to deliver that type of care. Not everything can be done over telehealth. Not everything can be done in that outpatient setting. And so that was some movement, some activity that we didn't necessarily see or predict, but we definitely kind of saw that come to fruition. And then I'd say the other big thing, I think we had initially thought of the COVID waves as this big, one initial wave, that we're going to ride it out, and it was going to kind of slowly trickle out. And I think, most of the world is kind of caught off guard by that. But I think the recurring waves have just continued to make it much harder for health systems to recover a lot of that lost care, to get operations back on track. A lot of those things, it's becoming a part of our daily routines and part of that within our daily operations. But just the recurring waves and what that's done to health systems financially has impacted decisions downstream, led to staffing challenges, and there's a lot more we could unpack there as well. And I think you might have muted yourself.
Sorry, my notifications are going off quite crazy, so I'm trying to minimize the disruption. Of course, I committed the ultimate sin of online presentations. So let's talk a little bit about this kind of trend that you had talked about with respect to national scale and the consolidation activity around that, and in particular, payviders, this sort of payer provider who is accelerating their growth, and the last couple years have been really interesting for them. So what have we seen there? Can you give me some examples, and what do you think is going to happen from here?
Sure. Yeah. So I think, this trend of the payvider has been happening for several years, but I totally think COVID was a catalyst and really just accelerating, the level of activity that's happened, the numbers of acquisitions that have happened in that space. I think it goes without saying, Optum, United Health Group, they're kind of continue to be the elephant in the room. I think they've snuck up on a lot of people. You look at a lot of industry experts and what folks are, kind of writing about them. People are surprised at the billions of dollars in revenue that they're, sharing out on their quarterly reports. And I even think I saw a number that they served over 100 million unique patients over the last year. So in 2021, I think they touched over 100 million lives. So that's nearly a third of the whole country. So they're a massive company that just keeps getting bigger. So Optum being the delivery part of United Health Group, United being the payer functions and a lot of the corresponding payer services. Optum, I think last year set a goal of employing an additional 10,000 providers, and they've, I believe they've been on track to meet that. I'm not sure if they officially met it, but they've quickly been growing their provider group size and targeting primary care groups, encroaching into multi-specialty clinics, things like that. They own a major ASC footprint as well, so they've really kind of garnered a big piece of the landscape, and it really lets them, on the United Health side, it lets them own more of that premium dollar up front. They can control where that goes, and then they also have the ability to control rates in a given market. If they have big enough market penetration, it lets them set rates within that for their own providers, and then as they're paying their own providers, they can have a little bit more control, a little bit more say into like what their medical loss ratios will look like, into how profits get distributed under the larger United Healthcare umbrella. So you've seen these big revenues, come through for United, but what they've been able to do is actually kind of keep more of that money and shift it accordingly, so they can hit federal mandated medical loss ratios and make sure where the premium dollar is actually getting spent as well.
Yeah, you talked a little bit about like Optum's growth goals, and I think they may, even before their target of hitting an additional 10,000 providers as employed within Optum, they were essentially the largest medical group in the country, right? So what do you think will be the ongoing potential impact of that on health systems, especially in light of this workforce crisis that was sort of always like in the background, right? It's been looming for some time, but got significantly accelerated over the course of the last couple of years. Like, what do you think the impact of that's going to be? And anything from a consolidation perspective, like to kind of counteract that?
Yeah, so I think the one of the biggest things that will happen is they do have the ability to control navigation. So site of care, which provider groups they're going to. So first and foremost, like that ability to navigate to route patients, that's going to impact health systems. If those specialty downstream referrals aren't coming through, that's going to have a negative impact on health systems for a lot of our own specialty groups and some of the downstream services that will come from that. And then secondly, kind of the bigger looming picture of what does that mean for recruiting physicians, retaining that clinical and medical, like that medical group talent. It gets harder and harder. I think the numbers I've seen over the course of 2021, but an additional 10 to 13%, I believe, of providers actually left health systems to join kind of like corporate entities, whether it's a retailer like Walgreens, CVS, someone like that, or be employed by one of the big pay providers like an Optum. So we're losing 10 to 13%. So it's around 20, 30,000 providers just left in over the past year alone. That's just going to further constrain health systems, limit what we can do, and then it can, and I'm a little bit nervous that it'll lead to some sort of spiraling effect where the providers who are left end up with more patients, more of the burden. They're still stuck dealing with some of the administrative burdens as well of working within a larger health system. So that's definitely top of mind for us, and thinking about how do we continue to serve our patients, to deliver high quality care to our patients. That's top of mind and really what we're here to do. But that it just gets increasingly competitive to retain those providers and keep them in house and employed.
Yeah, definitely. And we talked about Optum, which is of course a subsidiary of United Health Group, but even within the BUCAs, the Blue Cross, United, Cigna, and Anthem, like within those four, there are different strategies, right, as it relates to provider employment, provider consolidation. What can you tell us a little bit, just like, so we already talked about Optum, they're really going the like more employment route. Tell us a little bit about the other strategies that are out there, and then which kind of general trend do you think is ultimately going to win out?
Sure. So the overarching trend or theory that the pay providers are tackling is, hey, we want to own more of the premium dollar. And then we actually deliver that care as well. So you're not just keeping the premium and distributing it out and paying it to any old provider down the road. You're paying it to an entity that you own, or what other payers are doing is they're actually establishing value-based contracts with other provider organizations. And so they will maintain and kind of keep some skin in the game, if you will, and helping make sure that provider is delivering quality care, that they're meeting outcomes thresholds. There's a lot of ways you could structure a value-based care arrangement, but generally speaking, they'll have some upside risks, some upside and downside risk. It could go all the way to, the furthest end of the spectrum would be like a global capitation arrangement or a full cap arrangement, where all of the, as the provider, you're receiving all of the premium money, to deliver care, and it's ultimately your responsibility to kind of cover that patient from, through their whole continuum of their care journey, versus just carving out certain pieces of it where you'll get a certain percent of the premium to care for primary care, or a certain percent of the premium to care for child procedures and birthing procedures, things like that. So what we're seeing with, in contrast with Optum, you'll see Anthem and a lot of the regional Blues plans have actually said, hey, we're not going to go down the route of owning the providers. It's expensive. A lot of providers don't necessarily want to lose that autonomy if they're practicing independently. That's something they really value. So they don't really want to have to adhere to other standards, change their systems. It's hard.
Yep.
It's a lot of work. So what Anthem is doing is saying, hey, we're going to work with you to establish these value-based care arrangements. We're going to provide a technology support or a tech wraparound to enable that contract and make sure that we're better facilitating that contract and helping you maintain that, better maintain the outcomes for that patient. And then we can actually, between the payer and you as the provider, track how well that's going and understand what that means for our arrangement. And so it kind of lets them, it facilitates that arrangement. It eases it, if you will, on behalf of the provider, but they're not actually having to own and recruit those physicians. So it's a different approach, mainly seen through the regional Blues and what Anthem is doing. if I had to look into the future and say who's going to win, I think my approach is always to go look at history and see what history reveals. But I think going back into like the early 2000s, mid 2000s, Optum started down that pathway of supporting contracts and figuring out how they can better partner with specific provider groups and regions. I don't think it went as well. It's hard to track all the numbers all the way through, but they've shifted their strategy to owning the providers, and I imagine there's a reason why. I think my biggest hypothesis is that it's just going to be around. It's much harder to have those physicians operate against those contractual obligations. It's hard for them to change the way they're practicing, to think about those kind of standards as they're delivering care. They're focused on doing what's best and what's right for the patient all the time. And if the contract isn't necessarily as optimized as it could be, it's just going to be an extra burden, an extra headache for them. And so I think it's just I think what Optum or what United learned at least is just easier to own them outright. We can kind of control everything, versus what the lesson that maybe Anthem will learn, maybe not. That those are harder deals to arrange, harder contracts to to truly put into action than it may seem.
Yeah, it'll be interesting to see how things come out. There's certainly a level of integration challenges, incentive challenges that are present in the non-employed model, right? That will make it more difficult to operationalize potentially. Okay, let's shift gears a little bit. So, digital first, home-based modalities, kind of just digitally enabled care in general has seen a huge level of M&A acquisition activity, and a lot of like companies are just getting really high valuations. What stands out to you when we think about this, and do you think that trend is going to continue? And I'll stop there, and then I'm going to take a question actually from our audience as well.
Sure. So I think the biggest thing that I've noticed is both the depth and the breadth that a lot of companies are looking to achieve. A lot of the digital first modalities and those care models is they're not only saying, hey, we're going to just serve this small employer population where it's likely a high commercial payer mix, things like that, like you see with like perhaps what One Medical started off doing, but they're also expanding way broader. So they're going taking that broad stance approach, and they acquired Iora, so they're picked up a Medicare Advantage company as well, or a provider that covers the Medicare Advantage population. And so they kind of started off as this niche focus on a single population, and then they expanded really broadly. So that's like one big example or big trend that I think we saw. And then on top of that, a lot of these tech first companies have then added to a lot of depth into it as well. So we're saying, hey, we're not just going to deliver that care through these types of channels. We're also going to add on all these other program components. Whether it's pharmacy delivered to people's homes, and a lot of the pharmaceuticals that are shipped directly to your house, or even some of the remote monitoring programs out there. We saw a lot of clinics and other companies pick up remote monitoring assets that had been around for a while that always kind of struggled with some of the engagement, some of the adoption that we thought we would see probably 2, 3, 4, 5, 6 years ago. That didn't come to fruition. They said, hey, we have an engaged population. We have a better way to tie them in, better way to integrate them into our care model. And so we saw a lot of those other kind of, I think of them as kind of enabling technologies or enabling assets get added into some of these portfolios. And so I think they're really trying to round out what they can deliver, what are all the different touch points that you can engage with a patient throughout that care model. And then also just expand the breadth of the services or the population that they provide services to.
So related question then from the audience. So what do you see, and I know you've worked on this a little bit, so where do you see RPM, remote patient monitoring, playing a role with respect to what you just discussed around kind of the coverage around broader populations, the connectivity into the system, this sort of hybrid care model that a lot of folks have been talking about that bridges physical and digital. Like, how do you see it improving patient outcomes, access to care, like in perhaps like in geographically remote areas, more convenient care? Just tell me a little bit more about that. What do you think is going to happen in that space?
Yes, I think I where I've seen remote monitoring programs be more successful than not is where it's for like a targeted or a more specific use case. So I'm thinking like a great example is a lot of chronic care conditions, and looking at like we've explored this at Providence, and I'd say it's hard at a system level to integrate a remote monitoring program at large, without hyper focusing on specific populations. So if we're going to tackle a specific chronic care, so think about diabetes. We want to better track patients' glucose throughout the day. The companies that have scaled a solution, a care model really well focused on that patient population, I think they're going to be able to integrate a remote monitoring program really well into that care model, where it's additional touch points, where they're collecting that, not just collecting your information, but they actually have the team and the infrastructure on the other side to collect it, interpret it, and then reach back out to you as the patient, and actually interact with you, make suggestions, change the care model, change the prescription, like kind of having that continuous feedback loop where it's they're engaging with the patient much more frequently than you would in a traditional care model where you get your blood work pulled however many times a year. Then you meet with your primary care doctor, and they make recommendations, but it's much more sparse. It's not as quick of a feedback loop, and it's just much more challenging to put into to scale within a big organization. But if you're focused on this targeted population, you're focused on it like a specific use case, it gets much easier to make that change and to drive that better engagement with those patients. And I think that's really what will drive better outcomes ultimately for patients.
Yeah, that's really interesting, Doug. I think I heard you say a couple of things that are like really important takeaways. One is that it's, kind of remote patient monitoring as a capability will only get you so far, right? It has to be built into an actual care model that is really like, think about it as a tech-enabled service, not just as like delivering data and then hoping for the best, right? And then the second is like, in order for that care model to be effective, it needs to be targeted and segmented to a specific population. And I think that has a lot of implications, like from a consolidation perspective, right? Like to your point around One Medical acquiring Iora, it's folks are starting to get more sophisticated around not just the technology, but like how they think about populations and how all these different pieces kind of come together in a care model and in probably a broader platform to care for folks in a more sort of personalized, segmented, clinically appropriate, relevant way. So in that context, like, what do you think about point solutions within the context of digital health? There are, of course, like thousands and thousands of point solutions out there. And many of them are starting to get folded into other broader solutions. What do you think is going to be the trend there? Are we like moving away from point solutions? Do they have their place? I happen to think they do have their place, but they just over time become part of broader, sort of an integrated kind of approach to care delivery across a care, a tech-enabled service for special populations. But what do you think about that?
Yeah, no, good question. Really good question. I think my perspective is it's getting increasingly harder to be a standalone point solution. I do think there's a lot of wraparound technologies that have been designed to integrate with them, like utilize them well and kind of pull their information back in. That said, I think it's harder to go to market, or will be harder to go to market perhaps as a point solution moving forward. And I think this certainly came to fruition with like a lot of solutions that are sold directly into employers. And there are some interesting articles that came out about the benefits administrators at big employers having a hard time differentiating between specific point solutions. I think a lot of you could point to a lot of diabetes care management, a lot of wellness types of solutions, even I think it encroached into like the mental health space. But the benefits were hard to delineate between the two. And the benefits administrators were saying we're having a hard time picking one versus the other. But where the companies that had the greatest success selling into those employers was, hey, we can offer that mental health solution, the diabetes specific solution, the wellness engagement platform, all of those together, and they actually tie into each other. They speak with each other. It's we're going to still charge you the same amount, or maybe there's some price negotiation, if you will. But rather they're integrated. They're like kind of delivering a much more holistic approach, and it's a much easier for like the buyer to pick that. And I think that started with employers. I'm not sure. I imagine even some of the payers that will buy similar types of products might be experiencing that. And then even thinking about the other big buyers that are left are going to be health systems. They've been financially stressed throughout the pandemic. They may not be the biggest buyers moving forward, but they're going to want simple things, simple programs to run. They're going to want fewer integrations into any EHRs. That's always a costly endeavor. So like the fewer of those hits that you have to take administratively to get these programs up and running and achieve some of those goals, I do think that will just make it a little bit harder for point solutions to function on their own.
Yeah, let me, I'm going to take another question. I know we only have like a couple minutes left. I'm going to take another question from the audience, which is a little bit referring to something you already talked about. How do you see asynchronous care fitting into the picture? This person says, they think that the industry was fast to react to the pandemic by offering virtual visits by video, so like in real time. But what about modalities that like asynchronous chat, for instance, or messaging, which can improve patient access and generate efficiencies if through automation or assistive technologies? What do you think about that, and how does this fit into the consolidation picture?
Yeah, great question. I think those types of modalities, and I'm thinking of like a lot of like the chat-based solutions. 98.6 jumps into mind, but I do think those they have a place in in delivering care, and I do think they're probably some of the most effective at really providing a low-cost solution. That's kind of core to their belief, core to their value prop, and I do think they're effective at it. If you can communicate with a physician over text, it's quick responses. And it's relatively speaking a low cost of delivery. I think that that has a place. It's probably somewhere less than 10% of like the care that needs to be delivered, but there's certainly some great use cases for that. It's very, very convenient for patients, for parents, new parents in particular. You don't want to leave the house. You want to get your questions answered. You want to be able to snap a quick picture on your phone. And it doesn't get that much more convenient, for patients. Where that really will impact some of the kind of incumbent players is a lot of those visits will kind of be the first the first starting point or the first engagement point for a patient. If it can't be addressed through those asynchronous solutions, how does that care then get routed into the appropriate channels, whether it's an urgent care, whether it's an emergency room, whether it's a specialty provider? That's where incumbent health systems and even some of the pay providers will continue to have a play and say, hey, we got to figure out the routing. We have to figure out how these will interact with each other. We need this kind of seamless information. We need information to kind of transfer seamlessly. The last thing we want to do for patients is say, hey, repeat the same thing you already told the provider on over chat. You already sent pictures. They told you this information. I don't want to ask the same questions. It's a burden for patients. It's an administrative hurdle for our own providers to re-ask the same things. and for patients to have the kind of repeat the conversation. So if we can kind of better intake those as referrals or whatever we kind of treat them as, and integrate them into our kind of downstream, more complex care models, I think that'll be really, really important to do. It's easier said than done, but I think it'll really make those async visits much more valuable, that you can trust kind of behind the scenes, that you have those other connections into other providers as well.
Great. We are almost out of time. So I'm going to ask you, like, in the last 30 to 45 seconds, why should health systems care? Like, what's the headline? What's the key takeaway for health systems as they think about all of this consolidation and other activity that's happening right now that is maybe a little bit new to them, or just different from the way that we're used to thinking about things?
Yeah, so I think the biggest takeaway that I like to leave folks with is, it's important to understand like how the competitive landscape has evolved. But then I think like what we really need to be better at is looking at all the assets that we as health systems already have. We already have distributed clinics. We have critical care capabilities. We have the requisite physician networks. We kind of have all the assets that you need that everyone else is struggling to piece together. And I think we just have an opportunity to better utilize them, to better allocate some of those services, some of those resources that we have, like making it easier for patients to schedule appointments. It sounds simple. It's not, as we've learned, it's not as simple as we'd like it to be. But I do think like if we could better take our mental health providers for as an example, there's tremendous explosion of mental health, digital first, virtual first solutions out there. And there's just a critical shortage of those types of providers. So I think the onus is on us to better expose, our own resources and assets, and make it easier for patients to get in, to find us, to engage with us through different modalities, whether it's virtual or async to the question. And think about it from it doesn't have to be through a traditional insurance route. It could be through other marketplace-driven types of solutions. That it's kind of the onus is on health systems to evolve to catch up with the times a little bit, but we do have all the components. We just need to kind of redistribute them and re-expose them to our patients.
Wonderful. Well, thank you so much, Doug, for joining today. And thank you for everyone who listened and sending in your questions. To learn more about our initiatives, programs, services, ways to give, or if you're looking for medical care, please visit providence.org. And make sure to follow us on social media at Providence Health System for LinkedIn, Facebook, and Instagram, and under Providence on Twitter. So thanks again, everybody. Thank you, Doug, and looking forward to the next one of these. Take care, everyone.
Thanks, Sarah.